Our 10th and final pathogen group starts with varicella zoster virus, the cause of chickenpox and shingles. It is a herpes virus, and so a lot of times shingles is referred to as herpes zoster. So it's a herpes virus, and it is one of those viruses that will have it can have a very long latency period. So you have this latency following primary infection, and you will basically, once you got infected with this virus, you will probably never get rid of it. It will hide in your nerve ganglia, and it can be reactivated and resurface. Usually in children, the virus causes chickenpox, and in older people, it will cause shingles. There is an infant immunization available since 1995. Before that, there was about 4 million cases per year, with 11,000 hospitalizations and about 100 deaths in the United States. Most of the deaths were from secondary infections and pneumonias. There's also a risk of encephalitis and hemorrhagic disease. So this is a no-joke virus that was causing many problems before the vaccination became available. During pregnancy, there's a 5% risk of congenital varicella syndrome, and that could lead to limb abnormalities, cataracts, skin scarring, and CNS abnormalities in the baby. So here is a little kid with chickenpox, and these pustules that are forming, they're very itchy and they're fluid filled, so it's called a papullovesicular rash. And these kids are itching, they're not happy. It's a very uncomfortable disease, a very common childhood disease before the vaccination became available. The vaccination became immediately successful, and as of 2001, the vaccination against chickenpox is required for school entry, also for preschool and daycare usually. Here is an image that shows you how varicella virus from the initial infection moves up the peripheral nerves. So here is somebody having chickenpox, the initial infection, and then the virus will migrate into the nerves, up the neurons, and hide there. And it's the latent virus, and then it can be reactivated when your immune system is weak or something else happens, and then it can resurface later on in life as shingles, for example. So here is varicella virus causing shingles. Here you have this person, the virus was in the nerves and was basically hiding there probably for years, and then it got reactivated and moved back along peripheral nerve ends, and then it usually shingles. You will see it around the waist area, also the back area. So this is a typical spot where you would end up having a very similar papullovascular rash with these fluid-filled vesicles that are very itchy and very painful as well. So here, the latency following chickenpox. So here, the virus hiding in these peripheral nerve roots, and then once the virus gets reactivated, it will migrate up the nerve roots and then surface in various places on your skin. Here's somebody with shingles. You can see these fluid-filled vesicles right there, and that's a very typical area there in the back on the skin region right here, that with a virus then surfaces as shingles. Here's the shingles here in this back shoulder area on this person. Now there is a shingles vaccine nowadays available too, and it's got licensed in 2006, and in clinical trials this vaccine reduced the risk of shingles by 50%. Remember, you had to have the virus already, and so it's still hiding in your nerve roots, and now this vaccine can actually prevent the recurrence of this virus as shingles. And it also reduces the pain in people who still get shingles after being vaccinated. So these vesicles, this is very painful. And the recommendation currently is that anybody over 60 years of age should get a single dose of the shingles vaccine. Here's another image of somebody with shingles. You can see how inflamed the whole area is, and this is just very painful and also itchy. Moving on to other herpes viruses. Now we're going to take a look at herpes simplex viruses. We're going to specifically take a look at herpes simplex virus 1 and HSV2. Still same double-stranded DNA with envelope. That's typical of herpes viruses, and also the latency in the ganglia, the nerve ganglia. That's very typical of these herpes viruses. Common sites of where HSV 1 or 2 infections occur are oral, genital, fingers, eyes, on your butt, thighs, and then it can also be disseminated in infants that have a weak immune system. So here the virus typically moves up the nerves and then surfaces usually at the transition of a mucous membrane to regular skin. So you will have it on the lips, on nose, on the eyes, and the virus will still hide in the ganglia and it can resurface at any time. Here's somebody with oral herpes. So in this case, you have the virus hiding here in the ganglion, and it will migrate along this peripheral nerve and then just surface right there in the lip region. This is oral herpes, more oral herpes. This is pretty bad. This is also on the tongue right here. Very painful too. And here's oral and finger herpes. So there you have the herpes breakout right here, and then also in this area right here on the fingers. So basically multiple areas right here, also here on the lips, and you can see where the virus is surfacing right there. We have an image of genital herpes. This is herpes on the penis right here, so you can see the herpes blisters right there. And then here herpes on the finger right there, that's also referred to as whitlows. These are pretty deep lesions, and they're pretty painful and very inflamed, as you can see right there. Worst case scenario, you're going to have an infant right here with neonatal herpes, and this is really bad. So you can see this is even hard to look at, but this is like worst case scenario, the virus basically taking over the whole body here. Next up, we are having a classic sexually transmitted disease, gonorrhea, and the bacteria and the pathogen is called Neisseria gonorrhea. It's called the gonococcus, or GC, sometimes abbreviated. These are gram-negative diplococci, and they often intracellular and occurring inside of white blood cells. So here, so you see the gonococcus, these diplococci inside of a white blood cell. The transmission of gonorrhea is almost always sexually transmitted. Typically, the gonorrhea infection stays local at first, infecting membranes such as eye, throat, the rectum, urogenital areas, but it can become systemic if you don't take care of the problem. Untreated cases can also result in sterility in either sex and in pelvic inflammatory disease, PID, in females. So here are some pictures of somebody with gonorrhea. There's the typical pus discharge that you have right here on the penis area. So here the pus discharge also on females. There'll be over here on the left, that's a normal cervix. That's what it normally looks like. And then here we have all of this pus in the cervix here on the right side. Typical pus discharge. Here gonorrhea in the eyes. You also see the pus right there. Yeah, so typical pus here on the other side too. There's a lot of pus in the eyes. The diagnosis of gonorrhea is done. You can either do a classic culture, a gram stain, the slide and take a look at the bacterium. But nowadays, most of the time, you do a PCR test, so nucleic acid amplification test, that will establish the diagnosis of gonorrhea. And here, so in labs, the testing is almost always with nucleic acid amplification tests. You can also do a nucleic acid hybridization test, but the easiest and most effective way is to do a PCR test, nucleic acid amplification test. That's the standard. You do have to do this in a lab though. If you want to have a really fast diagnosis right there at the doctor's office, you can take a sample, a swab sample, and then do a gram stain, but you would have to have some trained technicians available that are able to do this, and also you end up sometimes with false positives. Moving on to another classic sexually transmitted disease, that's syphilis, and the bacterium that causes it, so the pathogen name is Treponema pallidum. It's a spirochete, as you can see here. It's stained, looks actually pretty nice. And the best viewing is with a dark field microscope, or you can do a silver impregnation stain. But this is what it looks like. It's a curved rod, and the transmission is almost always sexually transmitted. The general nature, it goes always systemic, and it has definite stages, and depending on how fast you take care of the problem, syphilis can go chronic, and it can kill you. So there are various variable symptoms associated with this stage, and we'll take a look at that. So primary syphilis is a lesion that has a funny name or an interesting name. That's called a chancre. I know it's spelled kind of weird, but that's how it's being spelled. So a chancre, that's the primary lesion in syphilis. It's basically an open sore, and you can see this over here. I circled here this sore. Interestingly, it does not hurt. It's an open sore, and it swarms with spirochetes. That means there's a lot of these Treponema pallidum bacteria are right there. Here's some more pictures of primary syphilis chancres, these open sores. You can see right here on the finger, or here will be this chancre here on the penis of some person. Once the progression is to secondary syphilis, then you can see there's a systemic reaction of skin rash all over the body. It can be variable, often on the palms of the hand and the soles of the feet. It doesn't itch still. It's flat oral and genital lesions that swarm with spirochetes again, and then you have head and body aches. The hair starts falling out, and so here somebody with you can see the rash on the palms of the hand, and here then somebody can also go into latent syphilis, and then there are no more symptoms, also even no transmission, not even sexual transmission, but it could be transplacental transmission at about 5 months of pregnancy, and that stage can last somewhere between 5 to 10 years, and potentially even longer than that. So once somebody's progressing to tertiary or late syphilis, this is when it gets really bad. Then you have damage to vital organs. It can be potentially fatal. You may have aneurysms of the arteries. That means blood vessels are breaking. You also have gradual degeneration of the brain, spinal cord. You end up with paralysis or psychosis. And the photo over here that looks weird is gamma, which is often internal. So you have serious damage to internal organs. Here's some information about congenital syphilis. So that means a pregnant woman has syphilis. What happens to the fetus? In 25% of untreated cases, the fetus will die. Another 25% of untreated cases, the babies die as newborns, as neonates. And then out of the 50% survivors, many have permanent birth defects or neurological damage. Here's a common effect of congenital syphilis, and it's called Hutchinson's teeth. You can see how the teeth here are deformed. It doesn't look right. It has these dents in there. And yeah, so that's a common result from congenital syphilis. And here the syphilis summary. So you have your stages there. The primary stage, those are these chancres, these open sores. They don't hurt, but they swarm me with those spirochetes. Then you have a secondary stage that can last on the order of years. You may even go into a latent stage that can last up to 10 years. So here will be latent stage, and then the tertiary stage, that's when you have organ damage and serious problems, even death. A bit of good news is that syphilis is easily treatable with penicillin. So as soon as penicillin became available, then you have this very sharp decline of syphilis cases because it became a treatable disease. Oh, lastly here, the diagnosis of syphilis. You can either do a dark field exam of basically a sample from the chancres, these lesions that are swarming with spirochetes, and then you can do a dark field exam of those spirochetes, or you can do a blood test, basically look for serum antibodies after primary syphilis.